The World Health Organization has now officially declared the Ebola outbreak in Africa a global public health emergency. And the reason behind that decision becomes even more alarming when you look at how fast the situation is unfolding across multiple countries. Right now, Uganda and the Democratic Republic of Congo are at the center of this outbreak, and together they've already reported 336 infections. Out of those cases, at least 88 people have lost their lives. But health officials believe the real numbers may actually be much higher than what's currently being reported. What makes this outbreak especially worrying is the particular strain involved. Ebola itself is caused by a family of viruses known as orthobilaviruses, but this outbreak is being driven by a rare strain called Bundibugyo. Unlike some other Ebola strains, there is currently no approved vaccine available for public use against this one. That changes everything. Because without vaccine protection, stopping the spread depends almost entirely on rapid detection, isolation, contact tracing, and public cooperation. And in regions already struggling with conflict, poverty, and weak healthcare systems, that becomes incredibly difficult. The WHO only declares a public health emergency of international concern during situations that are considered serious, unexpected, and capable of spreading beyond borders in ways that require international coordination. This is the same level of emergency declaration that has previously been used during major outbreaks like COVID-19, pox, swine flu, polio, Zika virus, and earlier Ebola epidemics. So when the WHO makes this kind of announcement, it signals that the outbreak is no longer being treated as a local issue. It becomes a global concern. The outbreak first began in the Democratic Republic of Congo. On May 5th, health authorities detected the virus, and by May 15th it had officially been confirmed as the Bundibugyo strain. Soon after, cases started appearing across the border in Uganda. 2 infections were even detected in Kampala, Uganda's capital city, which raised fears that the virus was no longer confined to isolated areas. Another major concern is Kinshasa, the largest city in the DRC and one of the most densely populated urban centers in Africa. A recent suspected Ebola case there eventually tested negative, which was a relief, but health experts are warning that it may only be a matter of time before the outbreak reaches the city. If that happens, controlling the virus becomes exponentially harder because of the massive population density and the constant movement of people in and out of the region. To understand why Ebola is treated with such urgency, it's important to understand how the virus spreads. Scientists believe African fruit bats are the natural hosts of Ebola viruses. Other animals like monkeys, apes, and antelope can become infected after contact with bats, and humans can then catch the virus through interaction with infected animals or infected people. The very first known human Ebola case was recorded in the DRC back in 1976. Since then, this has become the 17th Ebola outbreak linked to the region. The deadliest outbreak in history happened between 2014 and 2016 in West Africa. That epidemic was caused by the Zaire strain of Ebola and killed more than 11,000 people. Entire healthcare systems collapsed under the pressure, and the outbreak became one of the most feared public health disasters in modern history. Human-to-human transmission happens through direct contact with bodily fluids from an infected person. That includes blood, vomit, feces, sweat, and other fluids, even after the infected person has died. This is why Ebola outbreaks become so dangerous during caregiving and burial practices. Family members caring for sick relatives, as well as healthcare workers treating patients, face the highest risk of infection. The symptoms can begin very suddenly. Early signs often look similar to many common illnesses, which makes Ebola difficult to identify in the beginning. Patients may develop fever, fatigue, weakness, muscle pain, headaches, and sore throat. But as the disease progresses, the symptoms become far more severe. Vomiting and diarrhea begin, abdominal pain increases, and the virus starts damaging internal organs like the kidneys and liver. In many cases, organ failure follows. Some patients also experience internal and external bleeding, which is one of the reasons Ebola became so feared worldwide. Historically, Ebola has had an extremely high mortality rate. On average, around half of all infected patients die, although previous outbreaks have ranged anywhere from 25% to 90% mortality, depending on the strain involved and the level of medical care available. The current Bundibugyo strain appears to have a lower fatality rate of roughly 40%, But experts still consider it extremely dangerous because there is no vaccine protection available against it. And that raises an obvious question. If Ebola has existed for decades, why isn't there already a vaccine for the strain? The answer is that Ebola is not just one single virus. Different strains behave differently, which means vaccines developed for one strain may not fully protect against another. Right now, there are 2 approved Ebola vaccines, but both were primarily designed for other strains, especially the Zaire strain. The first vaccine is called Ervebo. It was introduced in 2015 and later used extensively during the 2018 to 2020 outbreaks in the DRC, where more than 345,000 people received it. The vaccine works by using a harmless protein from the Ebola virus to train the immune system to recognize and fight the infection without exposing the body to the live virus itself. The second vaccine is called Zabdino. This one has undergone clinical trials and is mostly used for frontline healthcare workers and people who had direct contact with infected patients. However, it requires 2 separate doses taken weeks apart, which makes it less practical during fast-moving emergency outbreaks where immediate protection is needed. As for the current Bundibugyo strain, vaccines are still being researched. So far, they've only reached the preclinical trial stage in animal models, meaning they are nowhere near large-scale public deployment yet. Because there's no targeted treatment or vaccine available for the strain, doctors can only focus on supportive care. Treatment mainly involves trying to keep the patient alive while the body fights the infection. That includes maintaining blood pressure, controlling vomiting and diarrhea, preventing dehydration, reducing fever, and managing pain. Patients who receive faster medical attention and supportive care generally have a better chance of survival. On the ground, the World Health Organization is coordinating a large Ebola surveillance and containment strategy. The response depends on several layers working together at the same time. Communities are informed about symptoms and prevention measures. Suspected cases are rapidly tested. Infected individuals are isolated, and contact tracing teams attempt to identify everyone who may have been exposed. Contact tracing is especially critical during Ebola outbreaks. Health teams identify every person who had physical contact with an infected individual and then monitor them daily for 21 days, which is considered the virus's maximum incubation period. If anyone begins showing symptoms during that time, they are immediately isolated and tested. Testing itself is carried out using real-time PCR technology and rapid antigen tests, similar to some of the diagnostic methods used during the COVID pandemic. These tests look for viral particles inside the body to confirm whether a person is infected. But controlling Ebola in this region involves challenges far beyond medicine alone. Many of the affected areas are difficult to access because of rough terrain and poor infrastructure. Ongoing armed conflict in parts of eastern Congo also makes it dangerous for healthcare workers to move freely. In some places, distrust of authorities and fear within communities can slow down response efforts even further. The outbreak's epicenter, Ituri province, creates another major problem. It's a busy mining region with large numbers of workers constantly moving between towns, health zones, and international borders. That constant movement increases the possibility that infected individuals could unknowingly carry the virus into new areas before symptoms even become obvious. There are also growing concerns about hospital safety. At least 4 healthcare workers have already died during the outbreak, suggesting that infection prevention systems inside medical facilities may not be strong enough. When healthcare workers themselves become infected, it not only weakens the response system, but also increases fear among both medical staff and local communities. Despite all these concerns, authorities have not recommended border closures at this stage. Instead, the World Health Organization and regional health agencies are urging both the DRC and Uganda to intensify contact tracing operations, expand laboratory testing capacity, strengthen infection control measures, and improve coordination between local and international health teams before the outbreak spreads further.